So the topic for the day for me is being the role of the dentist in maximizing OSA outcomes in children, which the previous speakers has made my life easier by Dr. Dr. Amlan and Dr. Vivek are talking about what pediatric OSA is all about and what are the challenges you are facing. So Thuyilcon 2.0, like that, I was also in 1.0, talking about the basics of pediatric OSA from a dental perspective. So I would like to give my 1.0 a brief on the previous presentation. How we look at the facial phenotypes, what are the signs and symptoms, how do we see the clinical examination, what is the workflow, what we do as a dentist and what are the investigations we do, and the management strategies. This presentation is going to be focusing on the quick diagnostic tools which you as an ENT surgeon can incorporate into your practice, and that could be your take-home messages, few diagnostic tools I'm going to give you, which you can see as from a dental perspective, very simple tools which can be of great help for you. And this is how the whole the perspective of looking at OSA from a dentofacial perspective looks very confusing. Okay, but what I have understood, I would like to reiterate to you. So basically, the anatomy, the habit, and the pathology. That's the obstruction. So the chicken and the egg dilemma, what we call. Usually we call it as the chicken and egg dilemma. Now we are calling it as the chick and the egg dilemma. Okay. What starts as an anatomical issue, that's a craniofacial anomaly, which may make the patient breathe through the mouth and cause adenotonsillar hypertrophy and loss of muscle tone. What could be a habitually breathing through the mouth, which causes adenotonsillar hypertrophy, which in turn changes the orofacial features and loss of muscle tone. What that could be an obstruction causing mouth breathing, because of which the loss of muscle tone and worsening of the orofacial features. So we are looking at the pathology correction, we are looking at the muscle tone improvement, and we are looking at the anatomy correction in terms of orodental devices. So that's how we are looking at it from a three-dimensional perspective of the whole disease. So that's the reiteration. But what generally happens is, when there is genetics, whether the parent is a class 2 schedule profile or a class 3 schedule profile, then the genetics also adds on, which makes the expression of the problem much more alarming in nature, and the pediatric OSA more severe in nature for the child. Okay, so dentist looks at it as a tongue airway mechanics, pulmonologist look as a ventilatory problem, ENT looks at it as a structural obstruction. The diagnostic anchor being PSG for pulmonologists, PSG plus dental imaging for dentists, and endoscopy or DICE for ENT. The PAP therapy, oral appliances, or surgery. So this is a single disorder looking from a different perspective from the different specialties. This is how it goes. So facial phenotypes, looking at the facial phenotypes, the convex facial profile is a very, very predominant profile which you see in pediatric OSA or STD patient. It doesn't mean only class 2, that's a class 2 profile what we call, means OSA or STD exists. Even in a class 3 it can exist. Even in a class 1 profile, you have a straight orthognathic profile, and if you have a loss of muscle tone, the chances for OSA or STD issues are higher. So you cannot entirely say, okay, the patient is going to have a retrognathic profile, mandible, or a high arch palate, then only OSA or STD is more prone. That is what we were talking about, but now the current literature completely has a different approach. So looking at the skeletal box, this is a static airway tool which we generally use, that's lateral cephalogram. In this lateral cephalogram, apart from looking at the airway, we also look at the CVF staging, the cervical vertebra staging, whether it's 2, 3, or 4, which indicates whether it's the right time to start treatment in terms of appliance therapy. Because the prepubertal growth spurt for boys and girls is a little different. So we need to target the child at the right age to get the right result. So we talk about the CVM staging, how to look at it, and when is a good time to intervene the maxilla, when is a good time to intervene the mandible, or it's a combination. Next, looking at the skeletal box, we have 3 planes: the transverse plane, the sagittal plane, and the anteroposterior plane. When we want to correct in all these 3 planes, you can have nasopharyngeal problems. When there's a transverse problem, you can have nasopharyngeal complex collapse. When you have vertical problem, you can have a long and narrow airway because of which the airway collapses. When you have an anteroposterior problem, you can have a pharyngeal collapse circumferentially or laterally. So in all 3 planes, whenever there is a craniofacial problem, the collapse can happen from the ENT perspective. So the approach is TVS approach. You correct the transverse first, the vertical next, and the sagittal third. So we are looking at targeting the dynamic start target is children, when the moving target, we are targeting. In adult, we are targeting a static target. So we need to time the treatment correctly. So this is the vertebrae maturation stages. So best time to do correction is in the CVM stage 2 and 3 for maxilla, 3 and 4 for maxilla and mandible. When the growth crosses beyond 4, the growth is almost complete. We are looking at surgical options for the patient. So this is how the vertebrae maturation starts. More trapezoidal in nature, becomes more square, and as age progresses, you get a rectangular shape, and the inferior border of the vertebra becomes more concave in nature as age progresses. So this is how we are looking at the cervical vertebrae maturation, and then deciding when to intervene in the maxilla, when to intervene in the mandible, or we are going to intervene in the maxilla and the mandible. So this is the prepubertal growth spurt. The good time to intervene for girls is between 10 to 12 years for mandible, 12 to 14 years for mandible for boys. So what exactly happens? Then we boil down to the functional matrix theory, that's called the Melvin-Moss functional matrix theory. What it says is nothing but the function precedes the form. When the function, the breathing, the swallowing is altered, the craniofacial development gets altered. So that's the basics of the growth and development, that's the basics of craniofacial development. The most accepted theory is called the Melvin-Moss functional matrix theory, which says that the function precedes the form, the function gets altered, the form gets altered. So we are looking at getting the function right, then the form automatically falls in place. So quick diagnostic tools which you can incorporate when you do a clinical evaluation. This is a tongue tie assessment tool. It's a scale which I have brought it for you. Maybe if you are interested, you can take it back home. I have a couple of scales with me today. So the other tool is called the mu facial scale, which helps you to assess whether the vertical axis is there or not. So this tool helps you to decide whether there is an anterior tongue tie or a posterior tongue tie, a very reliable tool which can give you an indication that there is restriction in the tongue. So this is a small instrument which we use for retraction and checking, and also during the surgical process, this tool helps us to retract and do the cut very precisely and very neatly. So basically what we ask the patient to do is just ask the patient to open the mouth completely and check the complete range of motion. The lower incisor is going to be the marking place in which you are going to keep the scale and get the baseline. Then make the patient open the mouth and ask the patient to do a lingual palatal suction and open the mouth. This gives you an idea whether the patient is lingual palatal suction like this. And keep the tongue on the palate and ask the patient to open the mouth. This gives you an indication that the posterior tongue tie is there or not, how much is the restriction. Then the anterior tongue tie, you ask the patient to touch the palatal surface of the incisor and open the mouth. That gives you an indication how much of anterior restriction is there. Okay, so this is how you do with the patient the static pictures. Okay, get the baseline, tongue tip to incisive papilla and the lingual palatal suction, and you get the total mouth opening, and in that how much is there for the incisive papilla and how much is there when the lingual palatal suction is done, gives you an idea of the anterior tongue motion and the posterior tongue motion. And with this scale, you will be able to diagnose and tell how much is the restriction, moderate restriction or severe restriction, and based on that, with the functional assessment, based on your history taking with the evaluation, you decide whether you want to nip the tongue tie, you need release or not. The next is the new scale. The new scale you use from the incisor surface to the tip of the nose. Tragus of the ear, the furthest point, you take the measurement and then you assess and you see whether there is excess or not. Normally, it should be 28 mm at the age of 5, and this increases 1 mm each year until puberty. So it should be average about 38 mm for average size boy and 36 mm for an average size girl. As a quick guide, what you can do is add 23 to their age. Suppose the child is 5 years, 23 plus 5 is 28. Suppose the boy is 7 years, girl is 7 years, 21 plus 7, 28. That's the normal for a child. And anything more than 5 mm extra to the baseline indicates there is vertical excess. Okay, so this is a very simple tool which helps us to identify whether the long and narrow face is existing for the patient or not. So this indicates when there exists upper jaw is rhesus, there is less room for the tongue to rest against the palate. Tongue position becomes low, drops forward during sleep. It's a cause of primary obstructive sleep apnea, and that is when the long and narrow face or the adequate face is sensitive. Okay, so this helps us to identify whether there is a vertical excess or not. So this is how we measure it. And for adults, you also can measure from the tip of the nose till the incisal surface. If it's between 38 to 40 mm, you have a normal vertical height, and for women, it's about 36 to 38. So this is how we assess the vertical axis for the patient. Now, the soft tissue profile masks the skeletal box when we do a clinical evaluation. So, to assess whether there is a problem in the skeletal box or not, a simple visual treatment objective, what we call as a VTO, is being done with the patient by asking the patient to bring the mandible forward. When they bring the mandible forward, if the profile improves, it indicates there is a problem in the mandible. The mandible is short. If the profile does not improve, it indicates that there is no problem in the mandible. The mandible is normal. So this helps us to assess. This is a very simple way to assess whether there is a skeletal box issue or not. So send the patient to a dentist to see them and further evaluate from the craniofacial perspective. So this normally you can ask the patient to do and just clinically evaluate. So these are three simple tools which you can rightly use to assess. Then coming to the intervention part, we are looking at expansion, we are looking at growth modification. These are a whole set of appliances in terms of growing child and a grown person. In terms of appliances, what we generally do, headgears, twin blocks, quad legs, Hyrax appliances, we just skim through all these type of appliances, how they look, and these are more, the top ones are more in terms of skeletal problem. The tongue grip, the oral screen, all these things are more, if the problem is more habitual in nature, we're looking at these options for the patient. So we look at the CVM state, the maxilla is narrow, we are looking at Hyrax expanders. If there is a class 3 profile, then also there is a nasopharyngeal complex narrowing. In that case, we are looking at expanding as well as pulling the jaw out with the help of headgears, and this gives us a very good idea, improvement in the nasal airflow, reducing the mouth breathing, improving the saturation, reducing the AHI, etc. When there is problem both in the maxilla and the mandible, then we are looking at twin block with Hyrax. This is a fixed appliance. Okay, the Hyrax is nothing but hygienic rapid expanders, which helps to expand the maxilla, and the twin block helps to bring the mandible forward. Then you see the results pre and post, how much of the airway improvement you see after the appliance is being given. Suppose the problem is in the maxillary axis as well as the mandible getting back, then we are looking at twin block with high pull headgear to bring the mandible forward as well as controlling the maxilla. So here the results after the pre and the post-op in the lateral self, the improvement in the airway dimensions, you can see the results. So in terms of mandibular advancement, if there is a vertical axis, also we need to control the vertical axis. In these kind, we go for vertical axis control with an appliance called the Herbst appliance to control the vertical axis. In terms of CBCT, we are looking at the mid-palate suture closure. There are various stages in which they get closed. If the suture is only partially closed and there is still room for growth, we are looking at Hyrax expanders. If there is almost growth is complete, then we are looking at mini screw assisted rapid palpal expansion, and that's in adolescents like 14, 15 and above. And if it's 18 and above, we are looking at surgically assisted rapid palpal expansion. So we look at this and we even select the tabs. That is a temporary anchorage device we use to hold the appliance and to split the mid-palatal suture, because that gives more of orthopedic force and opens the palatal suture, and thereby we get the transverse dimension increase. So we place the screw, we get the screw size determined before placing it in the patient's mouth. How much of anchorage I'm going to get, how much of bicortical anchorage I'm going to get, what is the height of the screw I'm going to place, whether the screw is going to engage on the roof of the palate, etc. will be predetermined before placing it in the patient's mouth. So this is how the appliance looks, and these screws will be there in the palate, which gives you that orthopedic force as well as the orthodontic force for the patient to expand the maxilla transverse. This is called mini screw assisted rapid palpal expansion. and this is how we assess the suture closures, and this helps us to open the sutures, get the maxillary expansion, increase nasal cavity volume, and reduce the nasal airway resistance. When the growth is complete, then we are looking at opening up the mid-palatine suture by means of corticotomy, and there is also buccal corticotomy done by the OMFS persons, and then we improve the transverse dimensions. And sometimes, in certain cases, even though we improve the upper maxilla, we also improve the mandible. Mandibular expansion is also done by giving a mid suture, mid symphysis split, and then we improve. And then, because sometimes the tongue becomes so big, it's not able to accommodate. So we also sometimes in certain cases we need to improve the mandible. So here also the same things which we lot of literature evidence is that it gives you a lot of relief in terms of improving the transverse dimensions, giving a lot of nasal cavity volume increase, breath, clinical outcomes of decrease in AHI, SpO2 improvement, and decrease in scoring. Sometimes if the problem is very habitual in nature or there is no major skeletal component involved, then we are looking at myobrace. In this kind of appliance is for borderline cases where there is no major skeletal component, only more of habitual in nature and little bit of dental compensation is there, then we are looking at myobrace. Correcting the alignment of the teeth and positioning the tongue and improving the breathing from oral breathing to nasal breathing. But this requires a little bit of compliance from the patient. It's a removable appliance. They have to regularly wear it in the night, but they are very good appliances. They can give dramatically good results. So these are scheduled class 3 corrections where the mandible is forward, where the maxilla is inward. So we are looking at in very young age, like 5 years, 4 years and all. We are looking at correction by means of an appliance called the tandem appliance. So tongue crib, only there is a problem in the tongue swallowing pattern. Then we are looking at an appliance called the tongue crib. We want to ensure that the tongue rests against the palate and proper swallowing happens. If the problem is only with mouth breathing, we are looking at an appliance called the oral screen, which improves the oral breathing pattern. At the end of the day, it's all about loss of muscle tone. So we are looking at improving the muscle tone. In any way the pathophysiology happens, we are looking at improving the muscle tone. So we are going to give the patient some exercises. So these are a few set of exercises generally we recommend to the patient and ask the patient to do. So teeth counting exercise, monkey face exercises, so many exercises, and we need to stringently follow the patient because compliance with children, as you know, is very difficult. So we make the patient do it. Doing it morning 5 minutes in the morning and 5 minutes in the night gives a good amount of improvement in the muscle tone to get the lip seal for better breathing, balloon blowing. So make it a little fun activity. We give them a small kit kind of thing, myofunction therapy kit, and make bubble blowing exercises, whistle blowing exercises. All these things get the circumferential muscles are getting strengthened, the tone gets improved for better lip seal and for better breathing. So at the end of the lecture, I would like to say that the take-home message is the maximizing the outcome in pediatric OSA lies in 4 variables. Timely intervention of the maxilla, mandible or both, integrating myofunctional therapy in airway management, identifying the primary cause of the problem, where the problem starts from, whether it's anatomy or it's a habit or it's obstruction. Then secondly, what is happening? So address it primarily where the problem is, and secondary problem comes next. Then, so you need to look at the pathophysiological origin in a dynamic target. It varies between children. Same child at different age might present it differently. So we need to know where to intervene, what to intervene, and how to intervene. So it all boils down to the pathophysiology, integrating multidisciplinary workflow. So the take-home message for all of you today is the new scale, tongue tie assessment tool, and how to do video. So shaping smile, supporting airway, transforming life, and it all depends upon the function. We are focusing on the function, the form gets right. So it all points down to the theory of Melvin-Moss functional matrix theory. And thanks for this opportunity by the team of Thuyilcon 2.0. See, adenoid facies patient, if it is there, first of all, when your patient is ready for surgery, always give them a hint that most of the time dental opinion after the surgery. But ideally, I would say once they are recovered from the surgical phase, maybe 4 to 6 weeks time, is a good time to evaluate from the dental point of view for us also. If they are okay with it, nothing like that. Okay, because always give them the thing, and if I see adenotonsillar hypertrophy, even if I see a craniofacial abnormality, I don't jump into and start working on the craniofacial aspect. I take the ENT opinion and then go. And moreover, what I feel when we work multidisciplinarily, our medico-legal support thing is also taken care very well in terms of this science, which is an evolving science. Because at the end of the day, they should not come and tell why you did not send me to a ENT or why they should not send me to a dentist. So medically also we are also protected in terms of when you're working in a multidisciplinary workflow. So that's very important. With experience, I am just telling this point. Okay, but if you can send it free, nothing like that. Okay, so because we will be able to tell them there is a long journey for them ahead. It's not surgery alone which is going to correct the whole issue. So they are also mentally prepared for it for the next phase.
Roshan speaking. Since then, actually, I have been following up my patients post adenotonsillectomy for a month, not 3 months. I told them after a month, please come back if your mouth breathing and your habits are not yet, because I started being conscious of this mind facial. Beautiful presentation. Another thing, one thing I must say, I was just telling my youngsters here, probably it's high time the ENT undergraduate textbooks change their opinion about indications for adenoidectomy. Remember, we were all told adenoid facies. But I think we should not wait till adenoid facies comes. As an ENT, we have to be conscious of a step beyond, before it, and refer, so that otherwise the treatment is more long-term.
So nowadays, OSA, when it comes, you get the adenoid facies. Before that, sleep disturbed breathing. SDB is what the more terminology they are using. So sleep disturbed breathing is prevalent among very commonly. If you have a grade 2 adenoids, also you will have a sleep disturbed breathing. That time itself, if we start working on it, we don't allow the patient to get into a grade 3 or grade 4. Then we will give it.
I see patients before surgery. If I see they already have these changes, I send them to orthodontists, talk to them about it and send them to orthodontics, because that is the time when they're receptive. So they need to understand. So post-op they come back.
Yeah.
3 months later, they know that this is the next step. Rather than when they come back, they say, now your child still has story, now you go to the orthodontist, that doesn't work.
The trust doesn't get,
yeah.
the light doesn't get.
They think I have failed, that's why I'm
sending them, exactly. First itself, if you said it's much more.
Yeah.
So working together is always better. Yes.
Thank you, doctor.